Cortisol is essential for long-term stress adaptation and glucose regulation. It's mostly protein bound, with only a small free fraction being biologically active. Clinically, cortisol prevents hypoglycemia by promoting gluconeogenesis, as well as mobilizing energy stores from cells. This is why cortisol deficiency leads to fatigue, hypoglycemia, and poor stress tolerance, while excess in cortisol can cause central obesity, muscle wasting, and metabolic complications. Cortisol itself suppresses multiple aspects of the immune and inflammatory response, and it does so by it stabilizes lysosomal membranes, reducing capillary permeability, decreasing cytokine production, and suppresses directly T cell activity. Clinically, this, if we kind of walk through this pathway, explains why glucocorticoids can be used to suppress immune function and can be used to treat autoimmune diseases, even things like asthma or allergic reaction. It also explains why chronic high cortisol weakens immunity and delays wound healing. Cortisol can decrease eosinophils and lymphocytes while increasing circulating neutrophils by demarginating them. Chronic high cortisol suppresses lymphoid tissue, decreasing antibody production. This is clinically significant in transplant medicine, chronic steroid use, and Cushing's syndrome, where patients are more susceptible to infection and have a reduced immune surveillance. Prolonged cortisol exposure contributes to muscle breakdown, persistent hyperglycemia, bone demineralization, and reproductive dysfunction. This is the physiologic basis of stress-related disease because chronic stress overactivates the hypothalamic pituitary axis or hypothalamus pituitary adrenal axis or the HPA axis, and that can generate real metabolic and immunologic consequences for the body. Patients may present with fatigue, poor healing, menstrual irregularities, or features that mimic an early Cushing's disease or Cushing's syndrome. So, how is cortisol regulated? Cortisol is regulated by the hypothalamic pituitary adrenal axis. CRH from the hypothalamus stimulates ACTH from the pituitary, which then stimulates cortisol production from the adrenal gland. Cortisol provides negative feedback at both levels, and it clinically distinguishing Cushing's syndrome from Cushing's disease will depend on understanding this axis in particular and determining whether cortisol overproduction is ACTH dependent or independent. There is a daily pattern of cortisol release that occurs because cortisol is released in a circadian rhythm. The highest amount is released in the early morning and the lowest amount around midnight in a typical normal healthy physiologic pattern. This pattern disappears though in Cushing's syndrome. Clinically, this is why timing of your blood draw matters, especially when measuring cortisol, because morning and midnight levels will provide different diagnostic values. So you have to clarify when ordering this in the lab which time you would want. And if you want this like first thing morning, if you want this before bed, you do need to be fairly specific with the lab. The morning spike is essential for waking glucose regulation as well as blood pressure maintenance. Most cortisol is bound to cortisol binding globulin or CBG, which is produced by the liver. Only free cortisol is biologically active. Conditions that raise estrogen, like pregnancy or even OCPs, oral contraceptives, can increase CBG and can falsely elevate total cortisol levels, which is why salivary or free cortisol measurement is often preferred in these situations for a more accurate result. Cortisol's half-life is also kind of short. It's only 90 minutes. It's metabolized in the liver where it's conjugated to glucuronic acid for renal excretion. Because clearance does depend on liver and kidney function, cortisol levels may be altered in hepatic failure or chronic kidney disease. This is also why urine-free cortisol can be elevated or unreliable in patients with renal impairment. And this is showing the relationship between cortisol and kind of that, what's decreasing in our immune system and its relationship with the hypothalamus, the pituitary, and the adrenal gland. So this is literally an image of our HPA axis. It's really important that we understand cortisol's metabolic role because we need to know how the body will adapt or not adapt to chronic stress. And it's foundational for us, especially as naturopathic doctors, for interpreting altered cortisol levels in clinic, whether we're looking at a serum, a saliva, or even a urine testing value. So we can look at kind of a general adaptation syndrome or general adaptation state of the body. And this describes the body's kind of three-phase response to stress. We have an alarm, a resistance, and an exhaustion response. Clinically, looking at this model, it helps us understand how acute stress is adaptive, but chronic stress leads to dysregulation. And it often manifests as fatigue, immune suppression, metabolic dysfunction, and eventually can lead to adrenal insufficiency in severe cases. This is looking at some of the long-term metabolic adjustments that occur, and it kind of reinforces that the resistance phase does require a sustained cortisol output. And so if the stressor to the body persists for too long, the system becomes depleted and cortisol regulation starts to fail. Patients in this latter phase may present with erratic cortisol patterns, sleep disturbances, and diminished resilience to physical or psychological stress. And ultimately, the exhaustion phase or collapse. This is where we see chronic HPA activation leading to maladaptive physiology. Clinically, this will overlap with conditions like chronic fatigue, burnout, immune dysfunction, and even worsening metabolic diseases. And it explains why stress management is not an optional component of endocrine health. It's actually therapeutic, or else we can see our body move through this exhaustive phase or this exhaustive step. So, how do we interpret and look at blood cortisol values? These reference ranges highlight kind of the normal diurnal variation, which is higher in the morning and lower in the afternoon, as we can see. Conditions that increase cortisol naturally could be pregnancy, physical and psychological stress as a maladaptive, and certain medications. But clinically, any cortisol value must be interpreted alongside timing, symptoms, and med history. When we come back, we'll look at some actual pathologies where we see this dysfunction play out.